Linda Napier. I'm the chairperson for the Healthcare Committee for the League of Women Voters. And this is Carol, who's been working very hard with me. Something very important happened yesterday morning. Representative Jack Hall has been working on an improved Medicare for All bill. And we didn't exactly know when it was going to be, I guess they say, dropped, but that was yesterday morning. There was a huge news conference, and it was very exciting. So I thought we'd take the first couple of minutes just to listen to the representative explain yesterday's big announcement.
My name is Pramila Jayapal. I'm proud to represent Washington's 7th Congressional District in the U.S. House of Representatives, and we stand here today because it is time to transform our healthcare system in America. It is time to ensure that healthcare is a right and not a privilege, guaranteed to every person in our country. It is time for Medicare for all. And I want to thank and recognize my Medicare for All caucus co-chair and my friend, Debbie Dingell, who is with us today. And you're going to hear from a number of our other colleagues in a moment. There are 107 original co-sponsors on this bill. That is double the number that we had on 676 initially when it was introduced, and I am confident we will just continue to increase that number, and I'm very grateful to all of my colleagues who have offered support and feedback and input. And in particular, I want to thank the many groups, and there are too many to name here today, who have been engaged for months, years, decades in some cases, on this issue and help to put together this proposal. And I just want to call out a small number first, the National Nurses United. Physicians for a National Health Plan. Social Security Works. The Center for Popular Democracy. Public Citizen. The Labor Campaign for Single Payer. Disability rights advocates, and so many more that have been part of bringing this bill into being. So we introduced this bill today with unprecedented support from labor unions that had never endorsed this concept before are with us today. You'll hear from some of them, the progressive community, the civil rights community, and you will hear from members who are in swing districts, because this issue resonates not only in red and blue districts, but also in swing districts. Everywhere, people understand that it is inconceivable that as the richest country in the world, that we would be the only major country that does not guarantee health care to every person. Today in the United States of America, 30 million people are uninsured. 40 million people are underinsured. And we have the most expensive healthcare system in the world. But here's the thing, we have some of the worst outcomes in the world. Our maternal mortality rate, moms who die in childbirth, is the highest of all of our peers. Our infant mortality rate, kids, babies who are dying, is the highest. And at the same time, our average life expectancy is actually going down, not going up. Every day, too many Americans are sick and dying because they can't afford insulin or cancer treatments. And that is even as the price of prescription drugs is soaring. The price of insurance premiums is going up by double digits overnight. Americans are filled with worry. They're foreclosing on homes, cutting their pills at the kitchen table in half to try to make them stretch out longer, and not going to see the doctor unless it's an emergency. 2/3 of all bankruptcies in the United States of America are because of medical issues. And GoFundMe is becoming one of the most popular insurance plans in the country. So why is it that other major countries can guarantee universal health care for half, literally half, the cost of what the United States spends, and yet we can't do it? It comes down to profit-making motives that are baked into a system that puts profits over patients. So even as people die because they can't afford treatments, the top pharmaceutical companies are raking in $75 billion a year in profits. In 2018 alone, the health and medical insurance industry took in $43 billion in profits. The United Health CEO took home $83 million. The Aetna CEO took home $59 million. And the Cigna CEO took home $44 million. So when you hear, which you will hear, that Medicare for all is unaffordable, just remember that the only ones who can't afford to let this bill pass are these pharma and insurance companies who stand to lose massive profits if we pass my bill. So my colleagues and I are standing here because we have a shared and deeply held conviction that everyone in America deserves quality health care, and we have a plan. Here's what our plan does. And by the way, I just put the bill in the hopper, and the number is 1384. HR 1384.
We have a bill.
We have a bill, and it is a real plan. So here's what the Expanded and Improved Medicare for All Act of 2019 does. First of all, we cover everyone. That's right. Everyone. Not just children, not just seniors, not just those who are healthy, not just those who have to get below a poverty threshold, not just those who might be fortunate enough to have employer health care. Everyone. Because health care is a human right. Whether you're rich or poor, you should have the same quality of guaranteed health care. Second, no copays, premiums, or deductibles. You can go to any doctor or hospital that you see. This is not a takeover of the Medicare system. You keep the same doctors and hospitals. You get to go see whoever you want because we want you to go see the doctor when you're sick. We want you to get your pharmaceutical drugs if you need them. We don't want you to spend hours on the phone with insurance companies or go to a hospital or doctor, be told that it's out of network, and then land up with a $20,000 bill. Third, we provide comprehensive coverage, including primary care, vision, dental, hearing, prescription drugs, mental health, substance abuse, maternal health care, and more. Your coverage will finally be based on medical necessity rather than what insurance companies are willing to pay for. Fourth, we control costs. We get rid of administrative waste, we negotiate drug prices, and we estimate that the average family who is already paying thousands of dollars for premiums, copays, and deductibles will actually pay less by 14% or so, depending on your estimates, and they will get better and comprehensive care. And finally, this is a big one. For the first time in history, we provide universal coverage for long-term care for individuals with disabilities and for older Americans with no cost sharing. And we flip the model on its head. Instead of saying institutional care is the default, we say, no, you should be able to be taken care of at home, in your community organizations, in places where you really feel safe and respected. And it's also finally time to acknowledge that the millions of Americans who are largely women who have left their jobs and risked their own financial stability to take care of their parents and relatives have the help that they need. So, is this a bold and ambitious plan? Damn straight it is. Because it has to be. The scale of our healthcare crisis is enormous, and our plan has to tackle the deep sickness within our for-profit system. Here's the thing. If we can end slavery, if we can give women the right to vote, if we can send a man to the moon, then God, we can do universal health care for every American. And don't forget that when we established Social Security, Medicare, and unemployment insurance, opponents said it was too hard. They said it was too difficult. Today is not going to be any different. You're going to see probably hundreds of millions of dollars flowing into trying to kill this bill, trying to pit us against each other, telling us that it is too expensive or that you're going to give something up. But we are ready. We can do this as long as every single person across America stands with us to organize, to fight, and to demand health care as a human right. And so I want to thank all of my colleagues that are here, and I see so many of them here. You're going to hear from some of them. Also want to recognize Jan Schakowsky, who just left, who's worked on health care for a long time. Want to thank John Conyers, people, John Dingell before him, people who have spent so long, their lives literally fighting for this issue. And I also...
My wife and I waited in a hospital room for the results of her colonoscopy.
We knew she was sick, and the look in the doctor's eye told us it was serious. It's stage 4 cancer at 28. We had 2 kids at home. Naomi worked hard in a factory in Michigan, a job that provided great health care, but when she became too sick to work, she lost that coverage when she needed it the most. That is the problem with our healthcare system, an employer-based healthcare system. We were given 2 choices in order to qualify for Medicaid. We could file for bankruptcy, or we could get a divorce. But the Affordable Care Act expanded Medicare coverage, and she was able to get the care that she needed, which gave us a few more years with her. Those states who have not expanded Medicaid are still faced with that heartbreaking choice. My job changed and she was able to get on my insurance. That's supposed to be good, right? She spent her remaining time battling with that insurance company so that they could do what I was paying them to do. Her doctor would make a minor change to her treatment. We'd have to go through a 2-week appeal process to get them to pay for it. Naomi missed chemotherapy injections waiting for those appeals. Naomi died in November of 2017 after nearly 5 years of battling with cancer and insurance. She envisioned a world where everyone had access to high-quality health care as a human right. Today, I am here with a message for every member of Congress. Support the Medicare Act of 2019 so that no one else has to make the choice between bankruptcy and divorcing the person that they love.
Tonight what we're going to try and do is give you some concrete information about a program that's very, very detailed, obviously. And it's not going to be like the one we had in December, which was when the UN, we had that celebration that the UN had decided to make healthcare, universal healthcare, their #1 priority. Tonight's going to be different than that presentation. We are going to give you a brief bit of background and history. Then we're going to talk about the myths and the facts that you'll need to know. Then we're going to close with a little bit of information that at that time it will be about my presentation, the main points, and Carol has put together an amazing flyer with all the places you can go to learn more, all the ways you can advocate, and some more about the myths and the facts. So I'm going to start with a question. Who has the Advantage program, Medicare Advantage? And who has just your regular Medicare? Oh, wow, that's amazing. Okay. And you know, I met a gal that was a nurse when she walked in. How many doctors, nurses, medical profession people do you have in there? Wonderful, wonderful. And I also wanted to ask, how many people know of somebody, maybe somebody in their family or maybe a friend who's never had trouble, inconvenience with not having enough money for something, having to wait, doctors being in the network, out of the network, denying care. So good, so maybe everybody can relate a little bit, because what I wanted to do is I wanted to tell you a little bit about why I became so personally involved in healthcare 3 years ago. We had just moved here, it was 2016, and we've been paying $1,000 a month for Blue Cross. And it was an okay policy, deductibles were still high, but when we moved here I had to change and Blue Cross wasn't here, so Cigna became the program. Well, it was $1,250, and I thought, well, okay, maybe a different state, that's how I reconcile that. But in that December, it said in 2017 I'd be paying $1,450, and it was going to be a $7,500 deductible for us each. Wow, it was quite a bit to swallow. So 2017 November, I get another letter from Cigna saying January 2018 it'd be $2,500 a month. No, $2,500 a month for T and I, my husband and I, and we're healthy. You know, it was a no-frills plan, $7,500 deductible. We could go to the doctor. Deductible each. Now that one was each. So we didn't want to pay $30,000 a year. We're in that group of 50 to 65 where people have worked a very long time. And they make a little bit over the subsidies that you can get, so we couldn't get subsidies. So there we were stuck, and there's that group, and I don't think anybody really kind of heard about, but it's the group of people that do make just over the amount so they can get the subsidies, and that's where the insurance companies keep the rates really high. So what do we have to do? Did you hear Jan Paul say the underinsured? For the first time in my life, I've had insurance since I was 20, paying for Blue Cross Blue Shield. First time in my life, I now canceled my insurance policy, and I have, well, now I have Medicare because at the end of the year, I got it, but my husband, so for all of last year, though, we had catastrophic only. So that still meant that we from doctors, dentists, vision, when we went to go to the doctor, we paid for that. So only if we had something catastrophic now do we have insurance. So that was just my experience with it, and why I've always been, since then, have been so passionate about working on healthcare so that nobody really has to go through that. Universal healthcare and the national insurance were first proposed by President Theodore Roosevelt, and then by Franklin D. Roosevelt, and then Harry S. Truman in 1945 as part of the Fair Deal. So just a little bit of history, 1945. But then it took until 1965 and President Johnson to actually get health care legislation passed to cover seniors 65 and over. So that's the very first time from 1945. 1965, Medicare was finally introduced. And if you would like this slideshow with all of my notes, all you have to do is, there's that little thing on the table where it has name, email, just write on the bottom of it, I'd like your slideshow, and I will send it off to you. Then you don't have to take notes if you don't want to. Now that Medicare bill that he signed was supposed to be the first step in an incremental for everybody, so that everybody would move up to healthcare. But as all of the other countries in the world passed us by, we made not just a small one like right away, but small one that's lasted over 50 years. So in the 70s, young people with permanent disabilities were added. In the 80s, hospice services were added. And in 2003, legislation was added that included filling gaps in prescription drug coverage.
What was the last thing you said? What gap?
Filling gaps in prescription drug prices happened in 2003.
I have a question.
So here we go. So write that question down. So in 2003 also what happened was HR 676, which was the very first improved and expanded Medicare Act. John Conyers brought that forward. And a small group of people started really working hard on that. It was originally crafted by physicians. And then, of course, we all know in 2010 the Affordable Care Act was passed. And although it was written by pharmaceutical and insurance companies, it was a step in the right direction in achieving coverage for more people and included some important coverage for the pre-existing conditions. And then, now that many more people had insurance, as you all know, they tried to take it away, and the country revolted. They wanted that insurance. So you can see from 1945 to 1965 was 20 years. And then all the way until now, it's taken finally for Medicare for All to really begin to get its foothold again. And so 2018, now we're up to today, the midterm elections, when candidates ran on Medicare for All and they won. Finally, with this new surge of support for all, Medicare for All, sometimes called single payer, the time has come. And the reason it's called single payer is because there's only one entity. Like, that pays the bills. So Medicare for all, if you hear Medicare for all and then you hear single payer, I think that's one thing. Okay? The people who've been working on single payer, of course, were very excited. And of course, because of the national support now. Those of us who support universal health care, along with the League of Women Voters, and I have the 5-page league position on health care, if anybody would like to read it, or I can send that to you too. In 2009, one or two groups were working on it. And now there are so many groups working on it that I don't even think you could count them all. And Carol and I have spent countless hours over the years, and just recently as well, and especially since yesterday, redoing the program to add all the wonderful new things now with this new bill. And so tonight we're going to try and put together a program that will be concise and hopefully graspable, because it is so detailed. So, what is the Medicare for All? And I think Jayapal said this one really, really well. It expands and improves the coverage. Everybody's in, nobody's out. Covers all the health needs. Just think of one. It covers them all. And the one that I was really excited about was the one for long-term care, where they flip it so that you think, oh, I could stay home, my community, there's another way to be able to be cared for. And the caregivers to be cared for with this as well. It would, of course, lower costs because of being able to negotiate. It eliminates all the premiums, co-pays, deductibles, co-insurance. Almost everyone will see an overall savings over the present system. And here's the big thing, it remains private. It's going to remain private. Not public. Insurance companies, we are the public. Medicare is public. Insurance companies are private.
It's privately delivered, publicly funded. That's
Privately delivered instead of publicly. Okay. This is one of my favorite slides because it kind of brings it down into a little bit more simple. Single payer. One entity is responsible for paying our medical bills, I just said that. Multiple payer. It's a chaotic system that is filled with bureaucratic inefficiency and waste. Just absolutely chaotic. Like that young man said with his wife spending the last years of her life trying to fight the insurance company just for her treatments. And then important medical decisions are left up to the healthcare provider and the patient, not between the insurance company And I want to give you another side that you will definitely hear about. So single payer, you see all the yeses. It's going to take care of all these things. But you'll also hear something called public option. And the public option, the difference is, and there's a lot of public options, the difference is it's still privately delivered. So there's still all of the cost. So it's not going to cover all U.S. residents. It does not eliminate co-pays and deductibles. It does not cover all necessary care or ensure choice of a doctor and control costs without compromising access to care. So when you hear public access, public option I should say, there's a whole bunch of different programs under that. And I'll tell you more about that. This I got from the physicians for a national health plan. And a lot of the, if anyone wants to see where Caroline found all these statistics, I would be glad to give you those. And most of them have it right on the bottom in small letters so people can look that up and I can send them the presentation of who that is. Now, a Medicare buy-in would only be one plan on the marketplace. So that's another option, but it's still on the marketplace. It's just another plan, more chaos, which would not get rid of the inefficient and costly multiple payer system. Also, it would be buying into Medicare as it currently is, which we know now is partially privatized. So I never realized this, but when you have Medicare Advantage, The insurance companies are still making their profits. So where their costs for overhead are up between 8 and 10%, Medicare's is 1.4 to 2%, depending on which study you read. So it's not, what they're doing is they're trying to privatize Medicare, which is our public program. So also, well, I probably have another place in the presentation, but no, I'll wait. Okay, so, and one more important point before we get to the miss. Remember how I said how many groups there were and how many groups there are now, so many, it's like hard to talk. There's a group called Partnership for America's Healthcare Future. Doesn't that sound wonderful? But what it is it was formed by an ad hoc alliance of private health interests, say insurance companies, people that don't want Medicare for all to happen. And it's not a real organization, it's just a name and a website and a place where these organizations can pool their money so that they can, like Jay Paul was saying, start propaganda campaigns to kill this bill. It's very important to them. This never even come up for a vote. Status quo is working well for them, as you heard Jay Paul say that. And their tactic, fear, uncertainty, and doubt. They even have a, what do you call it? An acronym. It's called FUD. That's what their tactic is. And the tactic is, and they're preparing all the advertising blitz about the horrors of a single-payer system. Well, what I want to do tonight, along with Carol, is show you that it's not so horrible. There's no horrors at all. Now, here's the good news. When it comes to access to healthcare, Americans are ready for a change. Finally. The stigma around single-payer has dropped over the years with broad majorities across party affiliation, supporting the idea of more governmental support to improve more Americans' access to health care. The bad news is that the private insurance industry is not going down without a fight, and they've got really deep pockets. And then in January, the Kaiser Family Foundation, another one of the resources that we use that's very, very, very reliable, released their monthly tracking poll. And the data was striking. It said 56% of Americans agree with Medicare for all. But on the other hand, the data also showed that when they were presented with even a couple of generic counter, it went down. And that's where the myths come in. So let's start with number one. Myths and facts don't fall for the false arguments. The uninsured get free health care. They can just go to the emergency room. Anybody heard that one? No? Oh, yes. Okay, the reality of it is the emergency department care is not free. Hospitals bill the uninsured at higher prices than insurance companies pay or taxpayers end up, and the taxpayers end up paying. Emergency rooms are ill-suited to provide primary care. And then how about this one? Unaffordable, it'll cause massive new taxes and inflation. That's scary, right? But this is on the flyer that we're going to give you, part of the flyer. We've put this on because I thought it put it together so nice. How do we pay for it? It eliminates unnecessary costs, it lowers expenses, and it uses money we already spend. So let's just take this on the left-hand side there, current spending for the public. We already have Medicare, Medicaid, ACA, TRICARE, Veterans, CHIP, IHS, and federal employees. That's already handled by the single payer, the government. It's our 2/3. We've already got those programs in place. 1/3 is household. It's our premiums, co-pays, deductibles, and co-insurance. Let's go over to the other side now. Medicare for all. So we've already got the existing public funding. And the new public dollars would come from payroll and other tax. That replaces what we are already paying for private insurance. Everybody gets health care, and overall spending is lower. So 95% of the people will pay less in health care than they do now. And this was a one that I found that I really loved. Where does your premium go? Okay, so of course, prescription drugs, physician services, outpatient services, inpatient services. But this last row, operating costs, 17.8, and net margin, 2.7. Remember all those profits she was saying in the millions, billions of dollars? That's that right there, 2.7. 17.8 operating costs are all of the administration. I'll show you. There you go. She was talking about this one. That's 2016. I think she had some updated figures. So there's part of that percentage right there. And then this one's another percent. This is another part of it. In the years leading up to and following the passage of the ACA, that's 2006 to 12, so 6 years, the health care sector spent $3.4 billion on lobbying. That's over $500 million a year on lobbying alone. So look at this little guy. I don't know if you can read it, but it's the insurance companies over on the left and the Congress on the right. And the insurance company is saying, and in exchange, you say we can't afford health reform. A whopping $709 million in campaign contributions over the same time period. So money in politics is a bipartisan problem. This is also an expense in that the column I'm showing you. Our health care dollars are going towards this and not toward our care. % of nonpartisan studies found it keeps costs flat or they decline. This is going to be important in one of my other slides, where it shows how fast things are going up. Even the Koch brothers backed study found improved Medicare for all saves money while expanding and improving coverage for everyone. So we're already paying for it, literally. We all understand that, obviously. But here's one that I put in on my own about employers. I didn't see this as a myth, but it was very important in the research we were doing about how it's affecting businesses, business owners. What are the costs to employers? Oh, and before I go on to the slide, there's one important thing in yesterday's bill. It was for the 2.5 million people that would likely lose their jobs. Because if we do this, there's going to be less paperwork. Okay? But what was exciting was this new bill that JFL has introduced. There's going to be 5 years of help for these people: retraining, education, retirement, paycheck, and I think it was Part 601, if I remember it, because I started reading the bill. And it was very interesting what they were going to provide for these people so that they could take that next step, so they just wouldn't be left out and say, well, it just happens. No, there's going to be a whole program for them to move on to another profession and have the money to do it. Okay, so here's my next slide. This one is showing that the chief financial officers agree healthcare costs are burdening businesses. And I just wanted to mention the one. It says most CFOs on the right acknowledge the strain healthcare costs place on their companies and the country. 81% of them are saying healthcare costs drain company resources that could be better used for other purposes, like maybe raising somebody's salary or new invention or marketing to build their companies. They feel powerless when it comes to managing their company's healthcare spending. So the employer-based healthcare that make up the foundation of our system isn't working, especially for the small businesses. There was a gentleman on the talking yesterday, and he was from a company called MCS Industries. He's the U.S. market leader for wall and poster frames. It's a huge, huge business. He has 200 employees. I suppose you would call it a small business if you were really huge. But he has 200 employees. He pays $2.7 million to cover their health insurance. $27,000 a year for a family, and $13.50 an hour per employee. Now, I was just thinking, gee, I kind of like that $13.50 added per hour to my salary. Plus, then they're already paying for their premium because the businesses are saying, gee, you got to help me out here. I can't pay for it all. And deductibles. So those are coming up for the employees. Okay.
How much are deductibles going up?
Well, what I'm saying is that the businesses are continuing to say we can't do it all. So the deductibles keep rising, as we know. So not only are the employees being asked to pay a portion, but they're also seeing in their insurance that their deductibles are rising. So the businesses are losing, the employees are losing. And his main point was this expense weakens competitiveness in the world for the U.S. companies. And I don't know if anybody's heard this one. There's another myth. Seniors on Social Security have to pay for Medicare and the supplemental insurance, and illegals get it for free. Not only is the factual basis for the question posed incorrect, but the suggestion that people in the U.S. illegally are a drain on the Medicare system is backwards. Now that's kind of what I usually hear, that illegal people are a drain on the system. But according to and I didn't know this, according to a 2015 study in the Journal of General Internal Medicine, those living in the U.S. illegally provide a net contribution to Medicare Trust Fund, just the Medicare Trust Fund, that largely pays for Medicare Part A, which is the free one for hospitals. From 2000 to 2011, such immigrants contributed a net total of $35.1 billion into the Medicare Trust Fund. According to the study, which was led by Leah Zalman at Harvard Medical School. So I thought, okay, I'd like to check this out a little bit more. Found out, yes, that's in fact true, but look at this. And this might not be part of my Medicare piece, but look at this. Undocumented Americans paid $23.6 billion in federal income taxes in 2015 using an individual taxpayer identification number. I didn't know that. $23.6 billion in federal income taxes in 2000. And that's by, I can read that little thing, source, Internal Revenue Service.
Amazon pays nothing.
Oh yes, and we do know that Amazon pays nothing and got $124 million, what, how much? Oh, okay. Single payer is fundamentally anti-American because America's capitalistic and individualistic society. Anti-American, our current system that discourages entrepreneurship because health insurance is tied to their employment. I'd say that's on the okay. Anti-American, our current system that leaves Americans vulnerable to skyrocketing health costs, so that 66% of all bankruptcies are related to medical bills. And I just wanted to put this in just to make the point that that number at the bottom could be anything. That was a 2016 figure, I think. But look at zeros for all of our other industrialized, wealthy nations. Zero. That kind of shameful. Single-payer to socialized medicine. Single-payer national health program is not socialized medicine. Providers, hospitals, and clinics remain private. And providers and patients make the decisions. Publicly funded, privately delivered, no rationing. The government pays for most health care, since single payer, but does not own or manage medical practices. So let's say, an example, that's our Medicare system. They don't own the hospitals that we go to, and we can go to anyone that accepts Medicare. We can go to any doctor across the country. Other examples would be Australia and Japan. And remember Australia and Japan, because there's a point in the future slides. And here's another one. We have the best healthcare system in the world. Why change it? Well, We spend more than any other nation in the world per capita on healthcare. And then, as JPO was saying, that says 78.8, but this was 2016. It's gone lower since then. And there's Australia, second from the top there, 82.5, with Switzerland at 83 years old. And our life expectancy is coming down. Maternal death rate is increasing. Look at this one. Look at all those downward lines going down, 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 and look at us going up. And then African American women are more than twice as likely to die than their white counterparts. So according to recent articles in The Atlantic and The Economist, the U.S. is seeing a two-year decline in the expectancy, and it's in part due to the opioid crisis. The opioid crisis. And this one I just wanted to show you because it shows here the top 19 countries in the world, and this kind of goes back to 2 years ago when I made the Healthcare Around the World presentation. And I tried to update these slides a bit. In 2016, it was $9,892 per person in the United States for healthcare. And let's go down to Japan. There we go, 4,000. And Australia, just a little over 4,000. So the average was $54.69. Okay. And this one I found one 2017. Look, it went up to 10,224 just in 1 year, from 9,892 to 10,224. What was really interesting is even though we went higher, the average went down. So all those other countries, healthcare actually went down on the average. Okay. And then I think it's important to see how our GDP has risen since 1960. And it's just a Canada comparison. This one, Canada kind of stayed steady. Of course, all healthcare is rising, so they rose up to about 11%. But we're up to 18.2 as it stands right now. And then this one was all the other countries in the in a larger study by the OECD. And do you know what OECD stands for? I can never remember. It's a long thing. Do you remember?
Organization of Economic
Organization for Economic. But it's a worldwide organization. That
It's
collects
in
facts.
developed countries in the world.
In developed countries in the world.
Right.
Okay. So as you, if there's Japan right there in the middle next to the red line, 9.5 is their GDP, and Australia is 9.1. But here's us way over to the left, 17.6, and of course I just told you it's up to 18.2 now. And that was, let me see, well that was 2010. 2012, I'm sorry.
What's the red one?
That's the average, 19.5 between all the other countries. I just want to put it in there, so we probably
I
raised
know what it was up here.
we read it a bit. Yeah. Okay. And so just another, this one's from the Commonwealth Fund in 2017. So higher performing on, they did the care process, the access, the administrative efficiency, equity, and health outcomes. And can you see this good? It's UK, Australia, there's Australia again, all the way down, Canada, France, US, lowest performing. Okay, here's another myth. We already have healthcare reform. The Affordable Care Act will take care of everybody who's uninsured. Projections for 2019 are 23 million Americans living without coverage. Single payer will restrict provider choice, which in reality, provider choice is already restricted under the current system because many private insurers severely limit the patient's ability to choose their doctors. one I thought was really good was we could travel the U.S. and be able to go to a doctor and not worry about it. No more out-of network. Quality of care will suffer under single payer. But I think we're seeing a trend here. It's not true. But I wanted to bring up these myths so that everybody could see when someone is saying that, they're probably just speaking from something else they heard, but they don't understand what, it took us so much time to learn about it. Most people don't have a lot of that much time. But single payer provides the most effective financial structure for increasing the quality and efficiency of care, and it facilitates large-scale adoption of quality improvement initiatives. Glad I saw that. My computer was dying. The electricity wasn't turned on. Okay. Doctors will never buy into single payer because it will interfere with their autonomy and decrease their salaries. But in truth, more than 60% of physicians already support a single payer system. The Physicians for a National Health Plan from the Nurses Association. That bill that she was talking about, the 1384 that she just released, it was written by the doctors and nurses and the unions and the people. It wasn't, there were no insurance companies, pharmaceutical companies that had anything to say about this bill. Okay, this is a slide that I just thought was so interesting. Watch that. See that red go up? See that little teeny green line on the bottom? That's how doctors have increased since 1970. See that huge, the number of doctors, percentage of doctors, from 0% to almost 3,000%. Okay. Administrators is the red increase, doctors is the green increase. So now we can see where some of the administrative money's going. Yes?
Administrators are like the middlemen, or does this include big pharma and big medical?
No, these are the administrators. I'm sorry, the administrators. Just the people that work in the hospitals and in the doctor's office that administrate, do the paperwork, talk to the insurance companies. Anything else? That's it? Okay.
But not the insurance companies.
No. This is just the administrative costs for the hospital.
Like when you go to the doctor and you've got 10 people, office people working there for one doctor, because you got dozens of insurance policies, and you got insurance companies, and then you got thousands of policies. So then you have to have all the staff that's doing your coding and sending out the bills, and then when they don't get paid, then they got to fight with the insurance companies. So they got all this staff in your doctor's offices and in your hospitals. So that's what that's showing.
Wow.
The increase needed for the healthcare. If we could just write that down. Healthcare is not a right. I know everybody's heard that one. But you know what, even if healthcare isn't a right, single payer might still be the wisest public policy because of its moral and the economy benefits. Moral benefits, tens of thousands of Americans die each year because they do not have adequate access to health care. Oops. I wanted to show you. On the bottom here I wrote in red, American Journal of Public Health in 2009 found that nearly 45,000 Americans die each year as a direct result of being uninsured. Single payer will create waiting lists. Single payer would result in rationing of care. Okay, we're already rationing healthcare in the United States. In the U.S., if you don't have insurance or ability to pay, there's no waiting list. You just don't get care. All scarce goods are rationed. Rationing in single payer system is according to your need. Rationing in the current system is according to your income. Can you pay for it? So how can we possibly transition from our current system to single payer? It seems impossible, and it kind of does, doesn't it? But they instituted Medicare in the 1960s in less than 1 year with no computers. Do you think we could do it with the internet, computers, and a system that's already been set up since 1965 that's working? Okay, I think we could. And Medicare accepts 10,000 new people a day. I think their system can handle it.
All they have to do is put all those administrators to work for the government.
Okay, single payer is politically unfeasible. Now, I think this one is probably the biggest one. Now, the good news again is, well, this one says 70%, KFF said 56%, but here we go. At least we've got a majority, including Republicans, supporting the healthcare for all. But again, I'm going to bring this one up again. These guys are going to try and stop it. And these, just not these guys. I mean, all the people under them. There's got to be a lot of management under there that are getting high salaries as well.
I said T
And
is
then-
for Medicaid.
Jackie was at the end.
Okay, and then this will continue if we don't stop it. There's your, yeah. So with our current healthcare system underperforming and the popularity of improved Medicare for all on the rise, this is why our elected officials are not moving. Why aren't they moving toward this policy? Money in politics is a bipartisan problem. This is also, these are also the expenses that we were talking about. The figure from yesterday was that over 600 billion would be saved. 600 billion would be saved. And this is how that number breaks down. Slashing the administrative waste, which is what you were asking about, of private insurance, and the paperwork insurers impose on hospitals and doctors, that's 504 billion. And bargaining down drug prices, that's 155 billion. 155 billion for bargaining down drug prices and other things. Without single-payer reform, the U.S. health spending is projected to reach 5.6 trillion by 2027. Trillion. Everybody right now is kind of struggling. I mean, we are. Everybody's struggling with out-of-pocket and premiums and co-pays. Doctors are struggling. They want to spend more time with their patients. But guess how much the GDP will be within? 19.4%. Dr. Claudia Fagan, she's a Chicago-based internal medicine physician with the Physicians for a National Health Plan. She's the national coordinator of the Physicians for National Health. Even single-payer opponents admit that compared to Medicare for all, the status quo will cost the U.S. $2 trillion more over the next decade, because it's 3.65 right now. How do they propose we pay for that? The system is failing both physicians and patients. Then Dr. Gaffney, who's the president of the Physicians for National Health Plan, he's a critical care physician and faculty member at Harvard Medical School, said yesterday, "Accept no substitutes. Only single-payer Medicare for all can fix the grave dysfunctions and injustices of the American healthcare system. Congress should not be distracted with incremental plans like Medicare buy-in or adoption. The only way to achieve universal comprehensive coverage is to eliminate the profits and waste of the private insurance industry, which drains hundreds of billions of dollars from our healthcare system each year." So if you had 3.65 trillion, which it is right now, to design a healthcare system worth 6.65 trillion, what would include? I thought it would include, if I thought about it, universal, affordable, accountable, accessible, comprehensive, high quality, evidence-based, and equitable. And of course, and thought about it, that's Medicare for all. So how are we going to do it? We would have to redesign the U.S. healthcare. And that's what J.F. Hall has been working on. That's what a lot of people have been working on for a very long time. So what can we do for the U.S. healthcare policy so it can be realized? Citizens and businesses outside the health sector must demand it. And what I'm going to do is some of the ladies have said they would pass around some of the sheets that I told you I would give you with all of the information in the program and the trifold that Carol put together. If you guys could do that right now, that would be wonderful so everybody can have it. So I also put something on the table. There's a sheet for everybody. It says how you could educate yourself in your community. Calling and writing the members of Congress. Supporting the elected candidates who champion improved Medicare for all. When you see somebody's running and you see them say, we aren't accepting any corporate money, PAC money, and they keep going on, no, they're not accepting, we're only accepting money from the public. These people are running to take care of you, the public. These are the people we need to elect. That's a great question to ask anybody that's running. And then now, when they answer you, you'll know, because you've got the facts, you'll know when they answer you, there's certain things like, create coalitions that can advocate together, meet with your members of Congress, organize town hall meetings like we're doing right now, presentations to civic groups and university symposiums. Men and women, join the League of Women Voters because we can show you how. We do everything from doing postcard things to going up to the Capitol and talking to our legislators to getting the big bus and going and marching and showing our support for the different things that we would like to support. So, Dr. Adams, another physician from the National Health Plan, passing Medicare for All system would buy our patients freedom. People would be out in the street demanding it if they really knew. So, let's tell them. So, fill out those papers on the table. If there's even one thing you can do, like sign a postcard, write your name and email address, and I'll let you know when we do that, or if you want to go to the Capitol with us. And now, we can open it up for questions. Yes?
I think one of the issues which has not been discussed here at all is something that will probably come up in a meeting, in trying to do this, and that is we have a lot of insurance companies in this country. And those insurance companies are owned by stockholders, and individual stockholders, by pension plans. Yes. They're publicly owned by a lot of people, individuals, and then through plans. So if we get Medicare for all, which I totally support that idea, the question still comes up, well, what happens to all the insurance companies? Do they just go bankrupt? And that's going to cause some economic issues, like when all the banks went down. It's going to cause a lot of turmoil. And somebody's going to have to pick up that cost, which is going to come back on. So how do you address that when that question comes?
So I should have given you the microphone because I was going to repeat your question, but it's kind of long. So what's going to happen to the insurance companies? What's going to happen to people that are invested in insurance companies? What's going to happen? Are going to go bankrupt? Well, they're not going to go bankrupt because a lot of insurance companies are in a lot more industries than just healthcare. They're in life insurance and all that kind of stuff. Now they're going to lose a lot of money, but Carol, can you answer?
Yeah, it's not the end of the insurance companies, because you have life insurance, car insurance, home insurance. So you have to think about how do you want to spend your health care dollars.
Well,
do you want to subsidize the profits of the insurance companies, or do you want it to go to health care?
I think the questions that are going to be asked of us is, even if the insurance companies are based over a wide product line, some of them may have a lot of health insurance that they're covering. They're going to lose that. That's going to take a big hit on them. So it's going to cause some economic turmoil. And it's, you know, it's not just the insurance companies. Those are owned by a lot of us, whether we have bought individual stocks in the insurance company, or whether we're in index funds, or whether it's in our pension funds. You know, we're going to take a hit there. So that's why they're fighting so hard, because it's going to be devastating for them, and it'll trickle down and be devastating for us. I still support the idea of Medicare for all. Don't misunderstand that. But this is a question that's going to come up by people who have investments there, who see that something's going to happen to them the other way around. So the question is, I think we need to be prepared to step up and have good answers for that, about what it's really going to take, and recognize that it's there, because by not recognizing it, we're going to seem to be at fault.
You know what, Sandy, I think that's a great question, and Carol and I are going to look deeper into that, because we haven't read the whole bill. It came out yesterday, it's 120 pages. I have no idea if there's any kind of wording there, but I'm sure that with all of our research, we've got somebody that we can find out a really good answer for that one. And then we can give that to you, and we'll give it to everybody.
Basically, we have to have a rebuttal for it.
Exactly.
We have to recognize it's a problem and come up with something that's...
And that's the whole thing about this evening, is coming up with giving you the ammunition to be able, when someone stands in front of you and says, well, it's socialistic medicine or something like that, so that they can answer, you can know how to answer. But that's a good one. That's a really good one. I want to know the answer to that one.
That's very
too.
important. This is one that I'm sure you'll be able to answer easily.
What about the need for restrictions on the billed cost of providers? Because now our Medicare it does cut down on the amount that's paid to a provider, as I'm sure we all know, right?
It wouldn't affect Medicare as we know it at all. And
Well, I mean, I'm saying in general, because providers are going to charge as much as they possibly can.
No, they won't, because it'll be government negotiated.
That's what I mean. That's
It'll
the
be
question.
negotiated.
That was the question.
Yes.
So each provider then will question, so a PCP will get so much per visit but per government. Government will decide.
No, the medical associations decide.
Well,
There's a coalition where the costs and the payments are going to be negotiated, which has doctors in it. So it's not just the government, but it's a coalition.
I read yesterday, when your red slide went up with the administrators, I read yesterday, it was on the internet, but I think it came out of USA Today, that an insurance administrator refused a patient's procedure without having read the medical file for that patient. So the decision was not with the doctor, not with the patient, but with a non-medical administrator who didn't even read the file.
no, but that's normal.
No, that's not normal.
That's normal?
They
No,
supposed
I mean,
to,
I don't think it's not normal that he didn't review the chart, but I think it's their decision is what I'm saying.
Yeah, but it's not good medicine.
No, it's terrible. I mean, I'm not saying it's good, I'm saying it's horrible. That's,
Did you turn the lights on, Chris?
how do we turn it on?
I've been on Medicare for about 3 years now, and I'm delighted with the coverage I get and the help I get from the physicians and everyone else. I have a question on the slide there. You had the U.S. average healthcare cost was $98, $92, I think, per person. Do you have a split on that Medicare versus all other people? Because I think that'd be an interesting fact to look at.
What was the question?
98, 92 was the average cost for healthcare in the United States per person per year. What does a Medicare patient pay on average, and then what does all other insured people pay to come up with that figure? Because it's got to be, I think Medicare is less than 98, 92, but how much is it? And then the second part of that question is, what does Medicare think about getting all these extra people on board? Have people have this outfit is pushing for the law, you showed yesterday. They must have to be really tight with Medicare and have a plan on how Medicare is going to step up their capacity to handle all the extra people. I guess that's
a great question, thanks.
So Medicare, let me back up a little bit here. So a lot of people say at this point, well, I'm afraid to do this because I'm going to lose my Medicare, or I'm going to lose my health, my employer-based health care. And the thing is, what are you going to lose? You're not going to lose anything. You're gaining. The reason that we can help finance this is right now the government spends 70%, as the one slide showed, through Medicare, Medicaid, the Affordable Care Act, the CHIP for children, your president, your Congress, your federal employees. So that's, you have 70% of our healthcare dollars now come from the government to cover things like your Medicare. So it's the government deciding how they want to spend that money. And the 600 billion, wasn't it? Yeah, 600 billion savings. If you get rid of that middleman, which is the insurance companies, all that money that doctors and hospitals and healthcare providers, that money, instead of going to all those huge CEO salaries, is going to be going to health care for everyone. So there's going to be savings there because you're getting rid of that middleman that you had just talked about that are not healthcare providers. Their bottom line is profit. So the Medicare for All, the reason that you got so many presidential candidates coming out with so many different bills, the public option, buying into Medicare, well, that's one of the options now is if you're 50, you'll be able to buy into. So they have all these different plans. So the insurance companies and big pharma and these chain hospitals are all pooling their money. And then what did they do with all this money to fight this, because they don't want to lose all those profits, is that they hired this PR firm, which happens to be a Democratic PR firm. And they have the inroads to go in and talk. You know, we try to get in and talk to our congressmen, you know, and they'll give us a photo op. But you got these guys that know them because they were the PR people all along that were working with the Democrats. And so they get in the office and they could say, oh, we can't afford this. So what you really need to do is you need to fix the Affordable Care Act. Or you need to have these other plans. Well, what all these other plans are is that the insurance company stays in business. And so they're the ones that can get the foot in the door. And you got all these people that, you know, these Congress people can't know everything about everything. So who do they look at? They look at lobbyists. And the lobbyists are going, this is not going to work because of all the reasons that we had discussed tonight. And so they're not able to hear the other people. Remember when they did the Affordable Care Act and they were doing all those, they had this group of people that gave ideas. We wanted to be at that table at that time. This is doctors and nurses. And they were not allowed at the table. So even when they were negotiating back then, they didn't have a seat at the table. So this is the first time that these doctors and nurses and healthcare providers have come together. And I think part of that is because everybody's getting so upset because their medications are going crazy and their co-pays are going crazy and everything's going up, that people are starting to rebel and looking at, okay, something has to be fixed, but what is it? So you're asking, how do they feel about that? And so the problem, the people that make the rules
are being lobbied with all this money that's available. So, in answer to your question, the Medicare, that's the government. That's us.
But do they have capacity to go
I think I have an answer to your question. It might not be a complete answer, but I started reading the bill, and part of the bill was how they're going to do that. And they're going to have regional offices, and they named the people then that would handle that region, and they had it all mapped out. The first bill that I was telling you about was 30 pages back in 2003. This one is 120 pages. It's a detailed plan, not just ideas.
So Medicare is protected.
Yeah, well, they put it together with the physicians and the nurses, and then if it's passed, they've got a plan for how it's going to happen. And so I don't know if you can say Medicare was sitting at their table, but then Medicare would do it.
That's
Yeah.
government.
It should be.
Yeah, and yes, there. And I was thinking too, when Carol was answering the question about the $9,892. Well, I just realized that, remember we're showing that pie? 2/3 of that's part of our GDP. So that part of the money is counted in the money that we spend. I wonder if that's all of it, that 2/3. Is that? Yeah, that's what I'm thinking. Isn't that the?
What is the cost per person on all the government programs currently? The ratio for those not including companies.
Isn't that it, Carol? Isn't that 2/3? That's per person. For that 2/3. That's it.
Well, you add all other.
Yeah, the 2/3 is the GDP and the 9,800 for the person.
That's not the 9,000, but you have all the private services.
No, that's just how much the government spends. Just how much our government spends, not how much we personally spend on top of that.
But you know, it's the government's efficient,
The efficiency of the 2/3, 2%. Their overhead is 2% for Medicare. Right. Right. They're paying all your bills. Yeah. Oh, well, I see that it depends on the person. Are you thinking if you have a $50,000 emergency surgery and I don't have anything? Yeah, so the average is, yeah. I don't have a Medicare number though. I just have the big number for all of them. Yeah.
Write that down.
Yes, we will find that out. We'll find, anybody else have a question?
I just have
Quick question?
kind of a weird, how are we going to get rid of the lobbyists, though?
Oh, yeah, is it?
I mean, aren't they going to, can you all even just hear me? That's all. Say that again, please. What are we going to do about the lobbyists that are going to just come out and force to try to, you know, that represent all the people that feel like they're going to lose their $1 billion pensions or whatever?
That's why I put this together, because it's up to us.
We have to.
People, it's up to the people.
To get
That's
to
why I
our
say- That's why
legislators.
she said it is a huge job. That was
So
her
let's
last-
get out there, guys.
Thanks, Susie, it's a huge job, and all we have to do is just a little bit each.
Just a little bit each.
No, a lot of it.
Well, a lot of it each, but if you can do only a little, please. I mean, I do a lot.
You do a lot.
How about do all you can? You know, as much as you can. And then I'll get back with anybody that wants to help in any way and hook you up with whoever is the person. I mean, it might be education. It might be health. It might be Voters' rights, that's who we are. It might be rights. We do a lot of good work, and we have a lot of fun. So thank you, everybody, so much.
To fight, I mean, we have to really, the grassroots really has to make this happen. Because the people that are making all the money now are going to be spending billions of dollars to protect that. And so we as individuals have to do our part. And that's why we were trying to give you the arguments of what they're going to be putting out there, that fake news. We wanted you to know what the truth was on the other side of that, because it's on, I'm watching TV. I mean, everywhere you look right now on TV, they're talking about Medicare for all. And they're spouting these fake facts out there. And I'm sitting there going crazy. Because there's nobody else on the, I really say, we have invested so much time looking into this. I think both of us know more than the TV hosts and the people in our Congress.
Yeah, in the Congress.
But the problem is for us to get in there, you know, I was watching one TV show and there was a guy that was actually knowledgeable about what Medicare for All was, and they just kept talking over him. So that's why we're thinking if we had a good committee here and we could go out to the community and give presentations, and somewhere I laid it, we've got these great DVDs. And so if you have a DVD player and you'd like to see that, or you'd like to take it to an organization that you belong to, or have people over to your home, we've got materials that you can use that are really good materials. And so if we don't start spreading the word, people are not going to hear that side of the story.
Yeah, there's just one thing. There's just one thing I think that should be added to that, is that we have to individually educate ourselves, right, so that when we have these meetings, we're prepared to answer the myths, to answer the things that, and use all the information you gave us here. But it's going to take, for me to do it, I feel like I'm going to have to spend some personal time really getting understanding, and not just that I saw your presentation, right, but I have internalized it so that I can spread it, because if we're not prepared. Yep.
I really planted her there. Because if you read this brochure, there are so many good websites out there that has so much information on it. So they're listed on here. There's simple things that you can do, plus ways to, you've got to educate yourself. I mean, we can't even handle all the questions that you gave us, as much time as we've spent trying to research this. There's a lot to it. And so these websites, I remember when I started back in 2009, and there was one group that I knew of that was working on this, and I'm now spending at least one night a week on conference calls. And learning so much by just being on these conference calls. The majority of these groups are set up by doctors and nurses who really have worked the system. I mean, I'm just somebody who's an advocate that's trying to learn as much as I can, but these guys have been in the trenches. So thank you for plugging my brochure.